So today I'm going to just, because there's lots of topics when you're talking about the mitral valve, I'm just going to talk about repair, and I'm going to try and be a little bit practical for you. And so I'm not going to talk about the access echo issues, but I will say one thing. When you're accessing from the groin, to avoid watching the cannula poke its way out through the ventricle, go through the following steps. Watch it in the IVC first, follow it up into the right atrium. Look at the line in the right atrium, make sure the line is not your PA or your CVL. Watch it go into the SVC. Be aware that most of the cannulae come with trocars or dilators that go in front of them. Watch the trocar come into the right atrium, watch it negotiate in the SVC. If you don't do those steps, you will see the trocar or the cannula out the side of the ventricle. So, perioperative MR is a bit of a different beast. You've got to remember that it's very different as soon as you start unloading people. You're reducing the peak systolic pressure, that changes pressure gradients. You change preload conditions, that has effects on effective regurgitant orifice areas. You generally decrease cardiac index. That translates to less backward flow and constant regurgitant fraction. And you get a booster effect from being intubated. People love, or left hearts love being intubated. They hate it being taken away from the end. Most patients love an anaesthetic. They just hate to be separated from us at the end. When you have MR, you've got to remember, it's simple stuff really. It's just morphology, mechanism, severity and sequelae. It's the same with every other valve lesion. You look at these sorts of things. I like to think of the mitral valve as a Pringle chip. It's the, as they say in that article from the JCVA, it's the perfect oval hyperbolic paraboloid, or a Pringle. But this is what the surgeon's trying to reconstruct. So you need to think of what they're trying to do, what tools they're going to use to do that, and where your measurements are going, where the anterior and posterior elements are, where the median and lateral elements are, how the commissures sit. And remember that when you're looking at annular heights and measuring heights, you're measuring a three-dimensional beast. You're not just measuring one plane. So if you measure in the BICOM view, you're measuring different levels. You're measuring at the AP view, you're measuring a different plane. That's where these things come from. And essentially, when we look in the perioperative context, all we're trying to do is give the surgeon the best tools for them to try and reconstruct an anatomical valve, because that beats anything else hands down. So certain valve lesions, though, have got specific issues that you want to try and address and look for. So if they're a Barlow's valve and you're thinking about repair, then you're contemplating a larger ring. You want to know how big is the ring going to be. You need to look at those dimensions because you don't want to undersize in a Barlow's. You want to buttress the posterior mitral leaflet. You want to give them direction about where all the pathology is. And when we talk about clefts, we're not really talking about sort of true anatomical deep congenital clefts. We're talking about sort of clefts in the posterior leaflet. So it's more exaggerated invaginations, really, rather than clefts. And then if they want to undersize for functional disease, you need to tell them whether they need to leaflet patch or look at cord release or reimplantation. And certain valve lesions need specific issues addressed. So if they've got rheumatic disease, they need to have fairly minimal calcification. The degree of anteromitral leaflet needs or mobility needs to be looked at. And if they've got endocarditis, it's very easy if they've got a little hole. But if they don't have a little hole, are they going to have sufficient tissue after they've debrided to repair? So morphology, more than anything else, is what we're really looking at. So once we looked at the morphology, they've got a lot of that from pre-op, but sometimes the quality of the images preoperatively aren't as good as what we can get under GA, where the patient's sort of flat out rather than fighting against the toe probe with the poor cardiologist up in the room where we're sort of underdosing them on various things. So you get a lot of time to just look at morphology, and that's really the key. And then you look at the mechanism of what's the leaflet motion, is there excessive or redundant leaflet tissue, is there commissure prolapse, is there annular dilatation, is it symmetric, is it asymmetric? Is there leaflet perforation or tethering by dyskinetic aneurysmal segments? Are the chordae long? Are they ruptured? Are they calcified? Are they fused? Those sorts of things. So, and then bearing in mind, pathologies tend to combine. So once you have a primary pathology, it tends to go on to a secondary pathology to sustain itself. So when you look at just simple M&M, this is classic restriction, but what you should be doing is focusing on where the pathology lies. Is it classic P2, P3? Is there posterior leaflet lag? Is the anteromitral leaflet unfolding? Does it have sufficient surface for cooptation when brought in with an undersized ring? So you've really got to look around at all these sorts of things. I can't, unfortunately, teach you how to do mitral valve examination in 30 minutes, but I can tell you about some of the things that we're looking at when we're looking at the valve. You know, this patient obviously has got bileaflet disease and they're going to benefit from a larger ring, but the exam should focus on what's the relative contribution of the cooptation from the anteromitral leaflet and the posteromitral leaflet. What are the caudal lengths? And what other problems, like clefts that might need placation, need to be addressed along the way? You get a bit more information about excessive leaflet tissue and those sorts of things from 3D, but I generally find that the 2D examination gives you all the information you want, apart from a few sort of other issues that I'll address later on as we get along. So apart from looking pretty, 3D actually does have some real advantages. Now, severity in the perioperative context for what we said is really a very difficult beast to address, and this becomes a real issue when you're trying to assess severity of postoperative leak. Preoperatively, it's not that much of an issue because that's already been established generally. By the time they've come to surgery, you're not going to turn around and say, well, I see their MR being a little bit less and they're not going to be done. It's been established on preoperative shots. But you need to understand that if you happen upon mitral regurgitation and you see it in the context of something else and you think it may well have been missed, then the severity becomes a real issue to try and assess. And the things that we we latch on to and get a bit more excited about is if we see sequelae of problems that are associated with severity of that valvular lesion. You know, is the LA enlarged? Is there atrial fibrillation? Is there LV dilatation and dysfunction? Has it led through to RV dysfunction, secondary TR? Is there pulmonary hypertension? So there's about 1,000 different indices of severity, and each one of them has pluses and minuses. But a couple of good, quick rules of thumb is that vena contracta is not very good in the mild to moderate sphere, but once you get much beyond 7 millimeters, you're really looking at severe disease. And but you need to have a proper picture. You need proximal convergence, you need narrowing of the stream, you need expansion into the left atrium. So you can't just have a fudged vena contracta. It needs to be a proper measurement. That's why doing PISA calculations in effective regurgitant orifice areas are quite useful. And it's quite a simple thing to do. The ERA, you know, you look at continuity equations, you get your regurgitant flow rate, you divide by the maximum gradient or maximum velocity through the valve, you can get a regurgitant volume from that. But you've got to remember the limitations of that as well. You know, it's mostly for singly centrally directed jets. It's not very good for multiple jets. It's not very good for highly eccentric jets. That said, you can put on a pretty quick rule of thumb. So if most people have got a blood pressure of 110 in cardiac surgery, and you put your Nyquist on 40, you can simplify the equation down to R squared on 2. And that means you can have a quick look at the PISA radius and go, well, 0.6 is mild, 0.8 is around moderate, 0.9 to 1. So if you see a PISA radius of greater than a centimetre and you've got your Nyquist on 40, you're probably going to be in trouble. Newer people or people are starting to look at 3D, and it's well appreciated that the hole in the mitral valve isn't just a single circle, it's an ellipse. So doing it with 3D might give some more information on working out these sort of gradings and helping with that. So that's severity, just a brief look at it, but really we come on to the M. So we're morphology, we're mechanism, and then there's this measurement thing. You might have seen the heart sheet from Leipzig. There's a sheet from the Americans as well. You see these measurements sit around and you often think, well, what am I doing these for? Why has my surgeon came and given me this measurement sort of thing to do? And so the two big important measurements are probably the AP and the BICOM, but you're really trying to get a shot of something that is very three-dimensional. And the problem is that anyone can be slightly off plane. And in fact, I think Stan and Sherman last year sort of grabbed 4 or 5 very experienced echocardiographers and got them to measure and then compare what he was getting on NPR with 3D. And so this is what you get on NPR or mitral valve analysis on 3D. You get those numbers up in the corner when you trace the leaflet and work the area out. And not surprisingly, when you start comparing what people get on 2D measurements compared to what they get on 3D, there's a lot of scatter when you do on TD. So that said, generally, you're not pinning that much on that measurement. You're trying to get an idea of the relative contributions of annular dilatation. Now, we used to believe that all annular dilatation was feasibly from this posterior side or stretched out, but that's being a bit debunked. So getting a real appreciation of what goes on. But generally, you're trying to give the surgeon an idea of what they need to do to restore the annulus with what ring. And that, I'll address that in a moment. Mitral valve area is another measurement that's being done, and you see that for eligibility criteria for Mitraclip, eligibility criteria for Alfieri stitch, and then for people who are not eligible for those who go on to some of those other interventions like Tendine or Gurrian, those sorts of things. You've got to bear in mind though, pressure half-time calculations assume a lot. So there's a 220 on pressure half-time for the mitral valve, there's a 180 for the tricuspid valve, but it assumes consistent compliance relationships between the left atrium and the left ventricle. So you're making a lot of assumptions when you're doing that, especially about diastolic function. So and with all Doppler indices, you know, when you go changing LVEDP, you change gradients between two chambers. These sort of influence the things. The interesting thing is that once you do a repair or Mitraclip, you can take a Doppler through either hole. It doesn't really seem to matter. At the back of our mind, when we're doing that pressure half-time, there's those eligibility criteria that already been addressed about Mitraclip. You know, so if you say, oh, well, I think this person's got ischemic MR, but it's only probably moderate, or we think it's only mild to moderate, can we address them down the line? There's not much point saying, well, I'm going to address them down the line of a Mitraclip if they're never eligible for a Mitraclip to start with. You might want to force your hand and talk about doing something about it there. So there's recommended anatomical criteria on those sorts of things in terms of depth of coaptation, flail, and orifice areas and areas to address. People who fail that can have percutaneous annuloplasties. We've done a Korean here. We used the toe and I put the person to sleep because it helped us find the coronary sinus, but then again, it's pretty big. It was pretty big, and this is the device in place, reducing the mitral annulus down. So the anteromitral leaflet length is another measurement that's in this measurement set that you're given, and it's a guide for the annuloplasty ring size primarily. So the big problem with it though is that it's very open to interpretation. You're meant to do it with it open with the valve and excluding the tip. But if you've got a myxomatous anteromitral leaf, what part's the myxomatous bad part, which part is the neutral part, which is the normal part? So you can see how it's very open to interpretation. You can find though, if you're going to repair a rheumatic valve, which is something I haven't seen here, but I did in New Zealand when I was there. Rheumatic repairs require about at least 26 millimetres of anteromitral leaflet tissue in that axis to repair, together with the minimal calcific disease. So that's another thing to look at or to consider in your mind when you're relaying this information across to the surgeon. Now, the LVOT is a fairly constant measure. You see that in the continuity equation with the ABA. So if someone's LVOT diameters change between various measurements, it's probably just wrong. The LVOT doesn't tend to change, and the constancy of the LVOT relates to the intertrigonal distance, and then you can estimate from that the estimated bandwidth. And that's quite useful when you're thinking about undersizing in particular, so you get an idea of what ring they should probably be at, and then how much room you've got to move when you're thinking of undersizing and what that might do. When you look at the picture, that's just another way of pictorially representing that. Because this person had like an LVOT of 22, an intertrigonal distance of 28, an estimated bandwidth of 30, but a 28 ring was placed. Now, bearing in mind, abnormal pressure and traction forces on the prosthesis are factors in early failure. So a short way after, it undersized and tore out. And you can see a big leak on the side. Person ended up with a replacement. So I think it's a useful thing to have in the mind that when you pass the information over to the surgeon about what sort of sizing they can do, because It'll determine the amount of traction. It also depends on what sort of ring they're going to use. Caudal lengths are another thing that are part of the measurement set. I tend to use the metaesophageal two-chamber view and also the transgastric long axis. The thing that you've got to bear in mind, though, is you've got to measure a normal part of the mitral valve. So if they've got Barlow's disease and everything's abnormal, you're not going to be able to really measure much. You have to reconstruct that saddle within the echo that you're doing in order to make the measurements make sense to them, because they're going to have the same problem. If as soon as the heart's flaccid and they put the thing in and they stretch it up, if everything's stretched, they're measuring against everything that's stretched. So they need to have an idea when the heart's actually ejecting of where the valve should sit. So sometimes you've just got to put planes across it and construct where you think the caudal length should be. The general rule is, though, never go too short. It's a lot more forgiving to be slightly long than to be slightly short. And also bear in mind where the chords are going. Are they primary, secondary, tertiary? And think about what chords they're actually trying to replace. Are they trying to buttress the posterior mitral leaflet? Are they trying to free it up? How much length do they want to put on? Now, Sam Maslow's criteria have sort of held up over the period of time, and increasingly this is the first question that I get asked when people walk in the room: what's the C-sept? You know, is it less than 2.5? Because that's when all those other things come into play. You know, the anterior malpositional slack mitral leaflet portions that suck into the LVAT are really only an issue if the C-sept is less than 2.5. Once you've done that, all those other calculations about the ratios of the leaflets come into play. The ratios really, though, are just trying to tell you how much is the coaptation point being dragged into the LVAT. That's all you're trying to look at. So with those measurements in mind, you've got to bear in mind what the surgeon is going to do. And people have said, well, rings and various other things, and there's complete rings and incomplete bands and segmental repairs and nice little pictures. But what you have to go out do is raid the cupboard in your surgical room and talk to your surgeon and see what they use. So at this institution, they use a lot of IMR rings and Physio 2s. So we've got some displays out there. You need to go and look at them and see what those rings are designed for and see what they're actually trying to achieve when you're looking at your echo study. You know, so the IMR it aims to reduce the AP dimension, improve the coaptation for AP dilatation. So if you've measured AP dilatation as the issue, and you can suggest, talk to the surgeon about that. And I'll say, well, I'll use an IMR ring, and you can say, well, I'll have a look at see if the P3 is tethered or not, because that's a consideration for those, because it's designed specifically to try and address that problem. You know, there's incomplete bands that are trying to preserve annular function from saddle shape. There's the Physio 2. A lot of this works from New York, from David Adams, I think, who's done a lot of this work following on from Compontier and done it for Edwards. And this one has that double shadow. It tries to optimize the distribution of stress. There's also devices from Medtronic, a Duran ankle ring and band, which has theoretically more flexibility and that sort of stuff. But the bottom line is you really just need to find out what rings your surgeon is using and see what they mean and what they want to use. And then that correlates to what you can tell them. You can say, well, this is what I find, and they'll say, oh, I might use this. And you can have a look at the things that might be associated with that ring for that surgery. So there's lots of surgical strategies. I'm not going to talk about those. There was a move away from resect to respect. Knee accordi, without a doubt, are more common now. There's also the edge-to-edge, which can get you out of some problems. And there's all these issues with cords. But again, I'll just emphasize that a key aspect is allowing enough movement of the leaflet and allowing a surface of coaptation. So you've got to remember that the valve has to come together and coapt like that. So if it's dragged down, it's not going to be able to coapt. So repair and replace, that's another conversation you're going to have when you look at the valve. You know, there's certain things that are going to make you push towards replace, especially, you know, endocarditis, rheumatic disease. If they debride a lot of it, and there's nothing left there to actually repair. That's problematic. Degenerative disease, it's pretty easy to say, well, we'll plan to repair most of those. And ischemic, it's still very controversial. Obviously, bileaflet disease, caudal shortening, no ring, no possibility of ring makes sway your argument one way or another. And as it's been outlined all through today, as far as I can tell, you need to understand the underlying disease process and the progression of that, because that will change the risk of MR that's underlying. If you don't address the ventricular problem with ischemic MR, you're probably just going to end up with recurrent MR. So, you know, on one side, we're more likely to repair if they're younger and well. You know, can they have if the first repair doesn't work, can they have a second bypass run, essentially? Can they have a third bypass run if that doesn't repair? Single scallop pathology is obviously easiest for the surgeons to repair. Annular dilatation is an easier problem to address. Multi-segmental pathology, you've heard some of the surgeons here already talk about how that can be very difficult to repair. Extensive rheumatic calcification can be very difficult to repair in endocardiac destruction. And then you get into the whole argument of ischemic MR, which I'm not going to address here. I'm just going to point out some features. But certainly when you're looking at repair, you've got to look at the viability of the myocardium, the postural wall function. You've got to I've had some sort of measure of the change in the regurgitation with exercise or dynamic change. If you're going to do it when you've launched into a cabbage, it needs to be at least moderate for you to go any further. There's that study in the New England Journal of Medicine only from last year looking at that very issue. And certainly if you've got a non-functional mechanism or gross annular dilatation, it makes repair or replacement a bit more compelling. We all know the mechanism of how ischemic tethering occurs, but there's also symmetric versus asymmetric tethering. These are some of the characteristics of those. But the thing that I'm sort of looking at is these sorts of measurements. You know, how dragged down is the anterior leaflet and posterior leaflet into the ventricle? What's the tenting height? What's the coaptation depth? What's the tenting area? And probably in the future, we're going to look at things like the sphericity index, which sort of places an imaginary sphere in the ventricle and compares it to LVEDP. And you can look at mitral valve VTI versus that index, and that's probably where these things are going to go. But for the moment, there's a couple of simple things that you can do to look at the risk of recurrent MR after trying to do an ischemic repair. One simple thing is just tenting height. You know, you place a cursor across the mitral annulus, you look at how far it's tented down. It's the same with all these angles, you know. You're just looking to see how sucked into the ventricle it is. So if you've got something that's like this, you drag it together, it's still going to have a hole in the middle. If you've got something like that and you bring it together, it's going to coapt. You need the surfaces to coapt. So that's tenting height. You know, you drag your cursors across, you do those sorts of things. I find that probably just as useful as doing tenting area. Here's a TTE tenting area that's been done. It is also useful to do ischemic indices on the 3D, so you can look at those. They come up when in the big green arrows. The MVN is a bit quicker at getting those than the MVQ, and probably we'll look at some of these indices together with those new indices down the line. So there's some of the considerations that we make when we're looking at ischemic MR and those sorts of measurements. All right, so you've decided to do repair, you think it's reparable, surgeon's done it, you've come with bypass, what are you going to look at? So you need to look at the ring position, and whether there's any paravalvular leak. You need to decide how much is going to be too much residual regurgitation. You need to decide whether there's stenosis, whether there's any SAM. Obviously, if there's been any change in the tricuspid or aortic valves. And then fortunately in repair, circumflex artery disruption and submanular disruption are quite rare. They're more the province of replacement. I don't think I've ever seen it in the context of repair. I think it relates to how the repair is done and how the rings are placed, but I suppose it could always happen. Never say never. So now, bear in mind, early recurrence of paravalvular leak is associated with technical aspects of the surgical implant, you know, the tension or abnormal pressure and traction forces on the prosthesis. Down the line, it's a different kettle of fish. You know, it's suture dehiscence from endocarditis or resorption, incomplete debrided areas, those sorts of things. So what are we looking at? Unfortunately, there's no golden rule on how this works, but the things that we're looking at is the shape and the orientation of the jet, the number of jets, the maximum velocity associated with the jets, what's happening with the pulmonary pressures, what's happening in the left atrium and the left atrial pressure, and what's the ratio of the leak to the total sewing ring that's been put in. And that, you know, you can see it on fast, or you can just do it with 2D by rotating, putting your colour on, watching it go through the sector of rotation and count the rotation sector that you've occupied. There's a couple of broad rules on rates of severity, but it does come down to a fair bit of interpretation. So how much regurgitation is too much? Again, unfortunately, this comes down to a matter of interpretation and when you look at, and these are the sorts of things that we want to look at. So first of all, you need the heart to be appropriately full. You need to look at what the LV function is doing, and you need to have an appropriate amount of afterload. All those things need to be addressed. If you ramp up the afterload too high, an overstretched heart, and it's dysfunctional, then you're probably not being fair to it. So you need to bear those things in mind. Now, there's a few studies out of New Zealand and a few other places around the world about trace to mild regurgitation probably being okay. But you also need to remember the perioperative context when you're doing that, and the severity is always going to be less because you've got all those booster effects that I talked about before. If you can quantitate by doing a PISA or ERO, that's good, but sometimes the jet's too eccentric for that to be possible or really to be an option. There are some coaptation measures that people have looked at in terms of the coaptation length and area, and having 8 millimeters of coaptation visible, akin to sort of in aortic valve repairs and those sorts of things. But it's a debatable thing. You've also got to think about what are the consequences of an additional pump run to try and fix this up, or a mitral valve replacement. If this person had a replacement, what's that going to look at compared to leaving them with a bit of MR? And then the big elephant in the room is, has the repair that you've done actually done enough to address the underlying pathologies? You know, if it's degenerative rather than ventricular dilatation, you've got a ring in and the regurgitation's a good mild, you've got an ERO of 0.15 or something like that, you might actually accept that because it's unlikely that the ventricular dilatation cycle will continue on. But if it's ischemic MR, that might not be acceptable because they're going to go on to dilate and tether, and there might be other issues at play. So you have to put the disease process that you're looking at in the context of what you're doing when you're making these assessments, and you're relaying the information to the surgeon for them to make a decision about whether they're going to do another repair or not. Stenosis initially is actually really uncommon if you can see the valve open. So if the valve is opening and a repair, it's pretty uncommon for you to find stenosis. And most gradients that people find are just a reflection of a hyperdynamic heart, so an increased cardiac output, or the patient is rather hemodilute. You've got to remember the Bernoulli equation changes when you move from being of a normal crit down to a hemodiluted. You've got to do 2V squared rather than 4V squared. But the computer will tell you just 4V squared because it's only used to doing that sort of stuff. It doesn't think the patient's got a hemoglobin of 65. Now, stenosis also is only really a problem of restrictive annuloplasty. And in a lot of ways, it's very difficult for us intraoperatively to assess that. You've already heard today about how exercise induces changes in gradients. Hello. More significant for trying to find functional mitral stenosis. And so that's unfortunately that's the situation in the immediate perioperative period, assessing that. Now, as mentioned before, SAM is especially an issue that you can see when you bring an undersized ring in and you drag the C-set down and bring the coaptation point. Other things like a small LV, a tall posterior leaflet, a narrow aortomitral angle and a large basal septum also increase the risk, as we know. So they're the sort of things that we look at.